Ladies and gentlemen, good morning, good afternoon, good evening, or good night to all of you, depending on your time zone and on when you are watching this seminar. I am Enrico Finazzi Agrò. I am live from Rome, Italy, and I'm live from, not actually from my hospital, but from another hospital, because my hospital is a COVID hospital. So in this moment, I'm doing surgery in another hospital, more in the city center of Rome. So I'm probably in a nicer place than I'm used to work, but still I'm, let's say, out from home. And this is not good, but as all of you, we have to face this period of the pandemic that is very, very hard for all of us. It is my pleasure to start this seminar. With two very well-known colleagues, as Professor Sanjay Sinha, and from India, from Hyderabad, India, and Professor Tufan from Istanbul, Turkey. It will be an issue-based discussion on LUTS, on lower urinary tract symptoms. I hope it will be interesting, and I hope that many of you may interact with us posing questions. So to start, we will have three parts. The first part will be on male LUTS. The second part will be on OAB, done by Sanjay. And the third part will be on stress incontinence and some prolapse also issues done by Tufan. So to start with my part, with male LUTS, this is the introduction, and these are my disclosures. And this is the first issue. Actually, this is related to this period of pandemia. We have a patient who is is in a waiting list for a QRP, and is having an indwelling catheter, so he's waiting anxiously to be operated. Sanjay, starting from you, what do you think? How long can we wait in a patient like this during the pandemic and after?
So, Enrico, by and large, TURP would not be categorized as an urgent surgery by any stretch of imagination. So it's not an urgent procedure. But at the same time, for somebody on a catheter, we cannot postpone the surgery indefinitely. So clearly, we have to go by whatever national guidelines and hospital recommendations are there. But I'm assuming that if the patient cannot get operated immediately because of the COVID pandemic, then I would assess whether this patient can perform intermittent catheterization in case we have to delay for a substantial period of time. That's one option. If the patient can't perform intermittent catheterization, or we don't have a healthcare worker who can teach intermittent catheterization, because that's quite possible, then I would see, does he have urethral problems, which would prevent us from continuing with an indwelling, or do we need to change to a suprapubic? If none of these problems are there, I would probably retain him on an indwelling catheter until we can operate at a somewhat priority. Enrico.
Yeah. Okay. Tufan, do you agree? Something to add?
Well, actually, I agree completely with Sanjay, but first of all, I would like to just express my thanks to you and Sanjay for just bringing together for this great webinar, and for the kind introduction to you, Enrico. It's really a great pleasure for me to be here. Well, I agree with Sanjay, but still we don't know the answer how long this COVID crisis is going to last. Well, in Turkey, for the time being, we are not allowed to operate elective cases in teaching hospitals and in university hospitals, but we are planning actually to just create a new normal for that. Maybe if we can pass to the second phase of the COVID crisis, I think, or I hope soon, maybe in coming weeks, we are going to be able and allowed actually by the health ministry to operate on cases like that, because here we have a patient on Foley catheter, and I'm sure that he also would like to undergo a surgery as soon as possible. So actually, I hope that we will be able soon in coming weeks to operate on this patient as well.
Thanks, Tufan. And just to conclude very briefly this small discussion, I think that now we have also guidelines from the EAU that show different priorities for different surgeries. And I think that a patient like that could be put in an intermediate priority, so can be postponed up to 3 or 4 months. But I think that it would be incorrect to postpone this patient more than this. So if the pandemic is lasting, unfortunately, more than this, we will have to even during the pandemic. The other point is exactly what the one was raised by Sanjay, that it's possible, it's possible to do an intermittent catheterization or to teach intermittent catheterization in these patients if whenever possible. And this should be preferable to indwelling catheter. This is a document of the Italian Society of Hemodynamics endorsed by the International Continence Society. This is a document on neurological patients, but in this part may be applied also to a patients with obstruction and an indwelling catheter. Let's go very quickly to the second question. This is not about the pandemic. This is a question of what to do in a patient with a contractile detrusor. Should we operate him? Should we do a TURP? What do you think, Tufan?
Well, this is a very important question, of course. We know that detrusor underactivity and a contractile detrusor is just a type of it, is a bad prognostic factor for TURP. But still, we can operate. We cannot say that it's contraindicated, but we have to inform our patients very well that actually he may still need clean intermittent catheterization after the surgery, and the success of such a surgery is lower compared to patients with a normal detrusor function. So my answer is yes, we may operate if the patient is under indwelling catheterization or CIC, and if he has a big prostate, especially with bladder protrusion, but the patient has to agree that he may still need clean intermittent catheterization after the surgery. Enrico?
Sanjay?
I agree with what Tufan said. I think the issue here is that when we use the term acontractility, we are not always meaning the same, implying the same thing. So when I say acontractility or when you say acontractility, what is the yardstick we've applied when we've done in the way we've done the test? So, did the patient have a recent history of an over-distended bladder, for instance, when you did the urodynamics? Did you do multiple cycles of testing? We've had patients where you do the first cycle, it appears acontractile. You do the second cycle, you find that the patient actually generates a contraction. Do you do a second sitting of urodynamics after an interval of a few days? So I think it's important to understand how was this term of this label of acontractile applied to the patient. So it's possible that a patient who's acontractile today, over a few weeks on intermittent catheterization, for instance, might show a detrusor contraction. So I would not certainly say that the patient would never ever get offered a TURP. I wouldn't put it that way. Certainly all patients need to be counseled. We know that there are some patients who will pass urine after being operated, and precisely for these reasons, because not all patients truly have an irreversible loss of contractility of the detrusor. So I think as long as we've explained the patient well, we know that about a quarter or so of patients in recent literature have actually voided urine when they've been operated. But as I said, we don't know the exact standard applied for the definition.
Thanks to both of you. I agree with what you said. Basically, TURP in patients with underactive detrusor, but still with some contractility, is something that can be done. We have the data from this meta-analysis published 3 years ago, actually. The results may be poorer in patients with not an underactive detrusor, but with not with a contractile, but with an underactive detrusor. Results may be poorer in terms of IPSS improvement, in terms of improvement of the maximum flow, but may be similar for the QL or the PVR, for instance. So it's something that can be done in an underactive detrusor. When there is a contractility, as you have correctly underlined, the risk of still be obliged to use an intermittent catheterization is high. According to this paper published by Blavis, the risk is around 70%. So there are 70% of patients that have to do intermittent catheterization still after surgery. Of course, the other possibility could be to try other treatment, as Sanjay has underlined. We don't know many times we don't know the exact pathophysiology of the problem. So if for instance, the pathophysiology is more related to, let's say, some kind of let's say neurogenic involvement in a way, it is possible that a treatment with, for instance, neuromodulation may be also able to let's say improve the situation, and maybe if done after or before surgery, the contractility may become a partial contractility, or at least partial contractility of the detrusor. I think that this can close this point, and I go quickly again to another point because we have many questions to answer. This is my third issue. The third issue is about antimuscarinic or mirabegron in male patients with LUTS. Sometimes, or usually, I don't know, in Italy it's very, let's say, uncommon to use antimuscarinic or mirabegron as first treatment in male LUTS patients. Usually urologists tend to use alpha blockers, for instance, first, and then as an add-on, antimuscarinic or mirabegron, or maybe as a combination treatment, but not as a standalone treatment. What do you think? And I start with Sanjay this time. What do you think, Sanjay? Can these drugs be used alone as a first line treatment, or should be used as only as sequential or combination treatment?
I think the literature is very clear on this, and we can use them alone. So use of antimuscarinics and mirabegron, both we can use them as a standalone treatment. So I would essentially triage my patients to see whether they have isolated storage symptoms, or do they have a combination of storage and voiding symptoms. Now, for the patients who have isolated storage symptoms, I would investigate to make sure that it's not a voiding problem masquerading as a storage symptom. And provided they're voiding well, they've got low residuals, isolated storage symptoms, I would be very comfortable starting them on an antimuscarinic or mirabegron as a standalone therapy. But if they've got a combination of both problems, I would probably start both together. But if they have a dominant voiding problem, then I might start just with the alpha blocker and see what happens. Storage symptoms might resolve. Enrico.
Tufan.
Yeah, it's the general attitude of all urologists, I think, in the world to start to every kind of lower urinary tract symptoms of men to treat with an alpha blocker. But I think we can, as Sanjay very clearly said, we can actually isolate here a patient group who present with isolated storage phase symptoms and who can very efficiently void, as can be shown very easily by uroflowmetry and PVR measurement. So I think this patient this patient group with isolated storage phase symptoms can be started to treat with an antimuscarinic or a beta-3 agonist initially without a combination therapy. And this actually also reminds us that overactive bladder is not only for women, but also for male population. So maybe we have the prostates, but it doesn't mean that all the problems that occur in our bladder is related to the prostate. So an overactive bladder can easily also just occur in the male bladder that can be treated with beta-3 agonists and antimuscarinics. Enrico?
I think that you did a very good job in replying this question.
Can I add a point, Enrico?
So, yes, of course.
In fact, the challenge happens when we've got these patients who have got somewhat elevated residuals, they've got storage symptoms, they deny much of a voiding problem. Those are really the challenging patients who are bothered by the storage symptom. But when you investigate, you find that they've got a residual which is somewhat elevated. Perhaps in those patients, the void efficiency is a better marker for what we should do rather than just in absolute terms how much the residual urine volume is. But if you remember, many years ago, Dr. Abrams from his center published that paper of about 100 patients or so who had urodynamic bladder outlet obstruction, and they only treated with antimuscarines. They didn't have mirabegron at that time. And they showed that retention was actually quite rare. But of course, those patients had residuals of less than 100, almost all those patients. So I think it seems fairly safe, but we need to be careful. We need to monitor them serially, see what happens.
Yeah, I agree perfectly with you, Sanjay. And I just want to show the guidelines from EAU showing that you can use these drugs as a standalone treatment or a combination or as an add-on treatment. But as you have underlined, both of you, we should remind that OAB can be also a man problem, not only a problem for women. And so sometimes we have to remind, but it's also true that we have also always to look at the voiding phase of our patients, because sometimes they are bothered by the filling phase symptoms more than from the voiding phase symptoms, that they may tend to, let's say, not to report the voiding phase symptoms. Now I go to my fourth and last question. Men with isolated nocturia. What do you think? And I would start this time from Tufan again. Tufan, what do you think? How would you study a man with isolated nocturia, and how would you treat him? And what if he's over 65 or under 65? Tufan.
Yeah. Isolated nocturia is actually not only a urological condition, so it requires to be thoroughly assessed. I think bladder diaries are very important and actually a must in the evaluation, and also to plan the treatment of this patient group. So we also know that nocturia is a very resistant symptom to a conventional urological treatments such as alpha blockers and TURP, for example. And also we know that over age 65, as you have asked me, the main reason of isolated nocturia or generally nocturia is nocturnal polyuria. So actually, I have to rule out all the possibilities that may lead to nocturia. And the bladder diaries, again, I have to emphasize, especially for the young residents and urologists who are listening to us, please do the bladder diaries. I know that it may be time consuming to explain to the patient, and sometimes we don't have time to do that, but you cannot treat nocturia without doing a bladder diary. Enrico?
Thanks, Tufan. Sanjay, briefly, if possible, a brief answer.
So Tufan has, I think, really told us the gist of it. Bladder diary, triage whether the patient has global polyuria, nocturnal polyuria, or a low mean voided volume in the night because of which they have their nocturia. And if it's a low mean voided volume, that could be urological, in which case see whether they've got problems of voiding with an elevated residual or problems of storage, and manage accordingly.
Thanks to both of you again, and I would like to show you my last slide that is about guidelines of the EU, and these guidelines probably summarize what you have said, that nocturia is something that is beyond the urological world. It's much more than this. It can be related to systemic conditions, sleep disorders, and so on. Can be differentiated in nocturnal polyuria or, let's say, simple nocturia. And in case of nocturnal polyuria, also it is possible to use the desmopressin with caution in all age, with particular caution in older patients. Of course, when nocturia is not isolated but combined with other symptoms, also other drugs for lower urinary tract symptoms may be considered. I would like to thank both of you for this discussion. I would like to give now the line to Sanjay for the next part.
Right, I hope you can see my slide now on the screen.
Yeah.
Yes.
You can. Right. So good evening, everybody, if you're in India, and good afternoon, morning, or night, depending on where you are. The mandate for me
glass of water.
Is to discuss overactive bladder and refractory urgency incontinence. And I've got 4 issues to discuss with you, and I hope I can go through all 4 of them over the next few minutes. Sorry for that. These are my disclosures. I have no specific financial agreement to disclose. So let's start with the first issue, and that is the sequencing of drugs for overactive bladder. So let me give a case 10 here. A 65-year-old woman, no comorbidities, bothersome symptoms despite all conservative measures. She's done everything that's recommended by all the guidelines. So let me start by asking Enrico, what's your choice of drug and what's your sequence of escalation? Enrico.
Yeah. Thanks, Sanjay. Actually, if we look to the guidelines, we have no particular reason to start with one drug or another. We can start from antimuscarinics, whatever the one we prefer, let's say, or with mirabegron. In some countries, there can be an economics aspect to be considered because antimuscarinics are generally cheaper and some of them are generic drugs now. So the cost should be considered. The other aspect that may be considered is the efficiency, the voiding efficiency, as you mentioned before, for another issue. Of course, when you have a patient with voiding difficulty, mirabegron may have an advantage, not acting, of course, on the muscarinic receptors, even if also the safety of these drugs has been already studied also in men with BPO. So I have no particular reasons to start with one or the other. Generally,
let me interrupt you for a short want of time and ask Tufan. Put you in the spot, Tufan. You've got to decide one medicine. I'm not giving you a choice. You got to tell me one medicine. What are you going to use for this later?
Well, this is a very tricky question, but Sanjay, I understand your point. I agree, first of all, what Enrico has said. This is also the situation in Turkey, because if you are treating in a state teaching hospital or university, you have to start oxybutynin because of just one simple reason, because it's the cheapest one. So, but I mean, I can start an antimuscarinic or a beta-3 agonist, but if I have to choose one, I would try first a mirabegron on this patient, just basically because in the short term, at least, it has a side effect very similar to placebo.
Sure. Enrico, just for argument's sake, let's say Tufan had started 5 milligrams and this patient came back to you saying that she's not responding well. What would be your choice after 5 milligrams of solifenacin for a patient not responding?
Yeah, I have different choices, actually. The first choice could be increasing the dosage of the solifenacin to go to 10 milligrams. The other choice could be to try another antimuscarinic drugs. The third choice could be to change to mirabegron, or even the fourth choice may be to do a combination treatment. The combination treatment is very difficult in Italy because patients have to pay out of pocket all the drugs. So to combine 2 drugs that they have to pay both, it's a little bit tricky. But I mean, I have not really a proper answer for this question for all patients. In a patient like that, probably I would try to increase the dosage, but of course also adverse events must be taken into account. If the patient is not completely happy with some adverse events, it's better probably to go for mirabegron.
Thanks. So let me conclude this issue by stating that the EAU, the AUA, and the Urological Society of India guidelines all recommend antimuscarinics or mirabegron as first line as a treatment for urgency urinary incontinence for patients who fail conservative therapy. The precise wording obviously differs from guideline to guideline. None of the guidelines have any recommendation with regard to the sequencing of drugs, but as Enrico very rightly mentioned, for patients with an inadequate response, escalation of dose, the trial of another drug in the same class, switching to a different class, or use of combination therapy are different options available for us. The USI guidelines suggest that instead of escalating the dose of the antimuscarinic, going for a combination with mirabegron is the preferred choice in that situation. And we actually have a combination kit available in India, which is reasonably priced. I will now go to the next issue, which is urodynamics for patients with refractory urgency incontinence. So let's assume that this patient did not respond to all the therapy that we offered. And we are now facing a situation where she's having bothersome symptoms and she is, so to say, refractory. So now I'm going to ask Tufan, when would you label your patient as refractory? Would you do urodynamics on these patients before treatment, Tufan?
Yeah, I mean, if I once label them refractory, before doing any additional invasive therapy, I will certainly do a urodynamic study. But, labeling patients with refractory overactive bladder is a tricky issue. In order to do that, I have to actually re-evaluate the patient from the beginning, like I see the patient first time in my life, because there may be many mistakes that we may have done or many things that we have not seen actually. So at least for me, two medical trials, two trials with different molecules are necessary, and at least a period of time of 3 to 6 months actually are also necessary for me to label a patient with refractory overactive bladder.
Okay. Enrico, short answer, please.
Short answer, I will try. First of all, a refractory for me is a patient who is not happy with the treatment, provided that I have studied her or him with bladder diaries. So I want to be sure that, let's say, the objective or semi-objective evaluation is done. If she's not happy, for me, this is refractory. Usually, I don't go to the second line or third line treatments before trying at least 2 drugs, but you could go on also after 1 drug not responded by the patients. Urodynamics. I think the urodynamics is useful not only to assess the detrusor overactivity, yes or no, but most important to understand the whole functional situation of the urinary tract of that person. And I think that voiding efficiency or the presence of voiding problems is a very important aspect to be ruled out, because if a patient may have obstruction or any kind of difficulty in voiding, this may condition the following therapeutic strategy in that patient.
Thanks, Enrico. Both Tufan and Enrico make some very good points. So if you look at the guidelines, EAU guideline does not define the condition of refractory urgency incontinence. The AUA guideline defines it, and they recommend the use of at least 1 antimuscarinic for 4 to 8 weeks and behavioral therapy before labeling a patient as refractory. The USI guidelines of 2019 has 2 additional points which we added to this. One was the need for using combination therapy before labeling a patient refractory, and the other was the necessity for examining a voiding diary before labeling a patient refractory. For want of time, I won't go into the details of this, but these 2 are required for labeling a patient as refractory. The other issue was regarding the use of guideline recommendations for urodynamics. So both the EAU as well as the AUA guidelines say that it is an individualized decision. The EAU guideline also states that the presence or absence of detrusor overactivity does not influence the outcome. The USI guideline has a recommendation for performing urodynamics for the reasons that Enrico and Tufan just said. It's a weak recommendation based on level 3 evidence. And the rationale for this was we felt that alternate diagnosis in patients referred as refractory to specialist units was significant enough in numbers to recommend the use of urodynamics before expensive and potentially invasive procedures which could carry complications. The next issue is regarding cough-associated detrusor overactivity, and I'm going to ask very briefly to Enrico, I think, for what he feels are the implications of cough-associated detrusor overactivity in the management of patients.
Yes, thank you, Sanjay. First of all, cough-associated detrusor overactivity is a urodynamic finding, so you can find this particular aspect only with invasive urodynamics, and this underlines to me the importance of making an invasive study, especially in patients that must be treated or that are supposed to be treated with a surgical procedure. Because catheter-associated detrusor activity is something that can be very confounding, because you may think it's stress incontinence, and on the other hand, it may be an urgency incontinence or detrusor activity incontinence, or both. Maybe also due to both to the cuff, so the stress part, and to the detrusor activity. So I think that this is an entity, and I appreciated very much the study you published on the topic. That is a little bit like a remark that we should always remember this problem when observing our patients. I think this is the most important concept.
Sorry. Yeah, just one sentence, because we are a little bit behind our time. This phenomenon is one of the reasons why I'm doing urodynamic studies prior to surgery to treat stress urinary incontinence on every patient.
Right. So both Tufan and Enrico have made some good points. And in fact, I would agree with Tufan. I also do urodynamics on all my patients before I operate them. Again, this is not probably the time to discuss the details of why. So cough-associated detrusor overactivity, I think for the residents and trainees, there's a very important issue that when you do the clinical stress test, a positive clinical stress test for stress incontinence implies that the leak starts with the cough and the leak ends with the cough. If the leak starts a fraction of a second after the cough started, or the leak continues beyond the end of the cough, this is not a positive stress test. It's probably a stress test confounded by cough-associated detrusor overactivity, or CADO. The AUA 2017 guideline document on stress incontinence discusses this issue and says it's a confounder of the clinical stress test and it's a finding of urodynamics. And the USI guidelines suggest that you should try and subclassify your patient in the text part of the guideline. And you can see here that the CADO is actually a heterogeneous entity, and you can have the leak either with the phasic contraction, which is the classical stress-induced detrusor overactivity that we always refer to, that's type 1, or patients may leak just with the index cough, that's type 2. They may leak with both the cough and the phasic contraction, or with neither. And this can have implications for treatment. This is a patient who has a type 2 CADO, where the leak happens only with the index cough. And this is a patient with type 3, where you can see a leak both with the index cough as well as with the phasic contraction. I think we are short on time, and I will stop at this point, and I will hand over this this discussion now to Tufan to continue with the next section, so that we can leave enough time for discussion. Tufan.
Yeah. Thank you very much, Sanjay. Yes. So, yeah. All right. So, hello everybody once again. It's a great pleasure for me to be in this webinar. And I also would like to thank everybody who's listening to us. I hope they have they are preparing good questions for us just in the last 10 minutes of this webinar. So these are my disclosures. So I will appreciate your very short answers here, please. I would like to ask about your opinion. Do you think that the COVID pandemic has changed our attitude to treat our patients with post-prostatectomy incontinence in the early period? I mean, between 1 to 6 months after surgery. So how do you plan conservative management of PPI in this period? Do you have special thoughts on pelvic floor exercises with or without biofeedback, or maybe some thoughts about medical treatment with duloxetine? I would like to start with Sanjay, please.
So I think even during the COVID pandemic, obviously we are not going to be doing any invasive therapies, and it might even be difficult to call this patient. But if, let's say, I'm doing a teleconsult with this patient, I would like to understand whether this so-called post-prostatectomy incontinence, is it because there's actually a complication of the original surgery which is manifesting as incontinence? Does the patient have a contracture, slow flow, large residual? So those kind of things. If it's not that, and it seems like a PPI, is the PPI having a significant bladder component to it? So is it likely that the patient has detrusor overactivity kind of a problem? So from the history, and I would like to judge this, and if I can, I would do some tests to check this so that I can triage my treatment. And clearly, I would try and teach the patient pelvic floor exercises either telephonically or, if possible, preferably in person, so that we can teach them.
Enrico, thank you very much, Sanjay.
Yes, thanks, Tufan. It's a very challenging question because in the last weeks it was almost impossible for us visiting in person patients like that, and so as Sanjay already stated, the alternative was basically a telephone consultation for those patients. And I agree with Sanjay, this is not really the most effective way to contact and to have, a discussion with those patients. But during the acute phase of the pandemic, it's possibly the only way to do it. Let's say in a more relaxed phase of the pandemic, I think that in presence, at least conversation with a patient like that is very important. Like to try to teach pelvic floor muscle exercises. I don't think that BFB is very important in male patients. This is at least my opinion, because usually male patients are aware of their pelvic floor, and what we usually call by BFB in male patients is only exercises. In other way, we can do BFB with our machines, but we are effectively doing pelvic floor muscle exercises. Maybe some physios may comment on that, but I think that this is what we usually do. I don't think that BFB is very important. Being very brief, so I think that in presence contact would be preferable, but in this period we may also have some tele consulting and some exercises at home. Duloxetine may be an option. Even if there is a study by the group of Giulio Popolo from Italy, from Florence, that showed that patients with duloxetine had an improvement, but after using the drug, when they stopped the drug, they were a little bit less continent. Let's say that patients doing only exercise of the pelvic floor, like they were a little bit more lazy in exercising because the drug was having some effects. Tufan.
Thank you very much, Enrico. Actually, I agree with two of our speakers. They have very well explained the situation. Unfortunately, the COVID pandemic has also affected our clinical practice in this field, because these patients are afraid actually to visit hospitals or our offices. But still, the first-line treatment of post-prostatectomy incontinence is the conservative management. And I hope that we will pass this time in order to go our normals back. So very quickly, I would like to continue with the second issue. The same disease, which is the post-prostatectomy incontinence during COVID pandemic, but now 1 year after surgery and radiotherapy. Just imagine, please, you have a patient with just complete workup, and the conservative management has failed, and you have already decided to implant an artificial urinary sphincter to this patient. So the question is, shall we still postpone the implantation of the sphincter in this COVID time, and until when? This patient just very obviously needs a sphincter implantation. And I would like to start now with Enrico, please.
Yeah, thank you, Tufan. No doubts, these patients need a surgical procedure, need an implant of an artificial sphincter. Unfortunately, during the acute phase of the pandemic, I don't think this is the good time for him to have surgery. There are several recommendations, either national or international, not to operate, let's say, non-urgent cases in this period. We don't know actually how the pandemic will last in our countries. So, if things will go better, I think that before or after we will be able to operate on a patient like that. I am afraid that these purely functional patients will be the less lucky, let's say, because they probably will have to wait even after the pandemic, because there will be other priorities, and we will have to fight also with other colleagues, other specialties, to have the operatory theater space to operate patients like that. But as soon as possible after the pandemic, a patient like that should be treated.
Thank you, Enrico. Sanjay, what are your thoughts about this issue?
He's in with for containment devices for a long period of time, unfortunately, under the given circumstances. This is an excellent patient to discuss a whole lot of issues related to radiation therapy and sphincter implantation, which is not your intention. But I think containment devices is what I would discuss in detail with this patient.
Mm-hmm. Thank you. Now to our third issue. Well, before I proceed to the third issue, I don't want to repeat what you have said, but I would like to emphasize that elective cases are in Turkey, for example, cancelled by national authorities or hospital management, like in many countries. And I hope, again, this decision may change in coming weeks or months. And as you have very well clarified, Sanjay, also written in the EAU guidelines, we have to offer incontinence pattern containment devices until we help our patients permanently. Actually, I would like to pass this third issue because I would like to obey my time. So I would like to share with you my fourth issue, because this is quite a problematic issue or case that we have to discuss properly. This is actually about a vault prolapse leading to bladder emptying problem and bilateral hydronephrosis in a lady during our time, which is the COVID pandemic. This is a 75-year-old lady with bladder emptying difficulty and recurrent febrile UTI. She underwent abdominal hysterectomy for a benign condition about 30 years ago. In the physical examination, you find a grade 4 vault prolapse, according to Bowden, with bilateral mild hydronephrosis as revealed by the ultrasound examination. And she consistently has a high residual urines, more than 200 milliliters. She is sexually inactive and has no urinary incontinence, also during the physical examination, which was done when her prolapse was reducted. She's on just one antihypertensive drug. She's otherwise quite healthy, and her renal function tests are normal so far. She cannot use pessaries, unfortunately. We have tried this on this lady, but she's not happy. She is not comfortable with pessaries. But again, she can void efficiently when her prolapse is reduced by pessaries. So I would like to ask here, Sanjay, how would you treat this patient?
So this patient, Tufan, is interesting in the sense that this cannot wait till the end of lockdown or whatever, because she's got bilateral hydronephrosis. There's a certain priority in treating this patient. So there's a matter of urgency here. Although renal function is normal, but this could change very rapidly. Her renal dysfunction is the key, and this renal dysfunction could be because of two main reasons that I can see. It could be secondary to the lower tract abnormality because she's got symptomatic voiding difficulty, she's got an elevated residual, and she's got recurrent febrile urinary tract infections, all suggesting a problem with the lower tract. So you could have hydronephrosis bilateral because of the lower tract abnormality, either storage or voiding problems, or it could be some form of structural or functional obstruction of the lower ureter due to kinking or whatever, causing hydronephrosis. Because of the way she's presented, I would probably discuss with her the placement of an indwelling catheter, because to empty the bladder just to see whether the hydronephrosis regresses. I'd also monitor her renal function, and if she's not settling down, then rather than put stents and things like that, I would think about doing a local regional anesthesia of vaginal corpoclysis or something. For she's sexually inactive at 75 if she accepts it, of course. Tufan.
Thank you very much, Sanjay, for this very clear answer. Enrico, what do you think? This is a problematic case, really. What do you think about it?
Yeah, it wouldn't be so problematic in a normal period. I mean, that everybody of us agrees that this is a patient that needs an operation. It's the prolapse to be corrected, not only for, let's say, air quality of life, but also for a medical issue that is this hydronephrosis that is consequent to the prolapse. So I think that the important point of this case is that functional urology or female urology, if you prefer, may be in some cases urgent. Maybe it may comprise also urgent procedures. I mean, so this is not a patient that can wait for 4 months, 5 months, 6 months. I mean, I think that we should consider this as not, I mean, an emergency procedure, but as an urgent procedure to be done as soon as possible. And then, of course, you can discuss how to proceed on this patient. I personally would prefer a sacrocolpopexy in a patient like that, but I mean, whatever you prefer for the correction of prostate. But for sure, even in this period, this is a patient with the priority to be operated as soon as safe, let's say.
Mm-hmm. Well, thank you very much, Enrico. Actually, just I brought up this issue on purpose because especially in the last 2 weeks, I have started to see patients actually like patients with intravesical obstruction due to benign prostatic enlargement, or cases also even like that with just high-grade prolapse. Actually, these patients were afraid to visit the hospitals because of the COVID pandemic, but they have actually developed upper tract disease because of obstruction. And I'm afraid that we are going to see more and more of this patient group if this COVID pandemic continues. So just as you have very well actually clarified, not all prolapse are benign conditions. So we have to be careful with prolapse also. And how to treat this patient is, of course, another discussion. I don't want to go into the detail for that. Of course, all surgical options are on the table, but especially like Sanjay said, we have also to include vaginal colpoclasis, especially in this patient group. This is a very, just an operation which makes the patient very happy. The only contraindication is, of course, sexual activity. But in the patient group where there is, if the patient is not sexually active, I think we have also to consider vaginal colpoclasis in this patient group. Well, thank you very much to both of you. I think we can proceed now with our Q&A section.
Okay, so let me straight away take on the Q&A section. And since we have a few questions and short time, I'm going to ask one of you each question rather than both of you for the answer. So this is a question by Luca. Is there an indication for stress incontinence surgery in patients leaking both with cough and with CADO? Tufan, would you like to answer that?
Well, I think the urodynamic investigation will here give us the answer. I mean, I want to know the compliance of the bladder here, and if also about the, let's say, severity of detrusor overactivity here. And this patient is actually having a mixed type of urinary incontinence. And if the urgency part is actually is more abundant than the stress part, I would certainly treat first the patient with, as I treat the overactive bladder, with antimuscarinics or beta-3 agonists, and to see what's going on. But if the patient has actually primarily a stress type of urinary incontinence, urodynamically proven, I can also proceed with surgery to treat stress urinary incontinence.
Thanks, Tufan. So I'll just add a little to that to say that the concept of CADO, the heterogeneity, is a relatively new concept which we published last year. So we don't have literature based on this concept. But what I would say based on what we have seen is if the patient leaks with cough, as you said, so patient has urodynamic stress incontinence, and the CADO is type 2 CADO, where the leakage happens only with the cough, I might think that this patient is a candidate for surgery. But otherwise, in general, the principle is treat the urgency component first, rather than the stress component, even in patients who have stress-dominant incontinence. Enrico, a very brief answer, so we go on to the next one.
No, it's not an answer. I just want to say hello to Luca, who is one of my residents working in Cambridge at this moment with Professor Castren. So I say hello to both of them.
Okay, so this is a question by, I don't know how to spell this, Cuneyd. I think this is a Turkish name from the flag. Enrico, I'm going to request. There's some here and there. So I'm so sorry that I'm not able to pronounce the name. What is the best time to begin duloxetine in patients with post-prostatectomy incontinence? Enrico, what's the best time to start duloxetine? Do you start duloxetine in place?
Actually, I don't know what is really the best moment. I can tell you what I usually do. I don't know if this is the best practice. Usually, I wait up to 3 months after surgery. We teach pelvic floor muscle exercises to our patients. And for the first, let's say, 3 months after the decatheterization of the patient, we usually don't do any active rehabilitation treatment or any pharmacological treatment. If after 3 months the patient is experiencing still an important disturbing incontinence, then we start rehabilitation, and sometimes for very motivated patients who are very bothered by the symptoms, we use together. So at 3 months also duloxetine. So this is my clinical behavior. I don't know if this is the best way to do.
Right. So I'll just close this, the answer to this by adding to what Enrico said, that duloxetine is a drug to be used with caution. The number needed to harm is relatively low. So the risk-benefit needs to be very carefully assessed before you prescribe it. Any benefits of duloxetine is primarily only in the early period because it doesn't seem to change the natural history of disease. So patients will become continent a little faster if they're on duloxetine, but the ultimate continence rate does not change. So if at all you're using it, use it early and be sure that you're monitoring for side effects.
Sanjay?
Tufan, yeah.
Just I want to mention that the quality of evidence, I mean, about duloxetine is actually requires more randomized studies in order to decide.
Sure. In the last 10 years. I think there are only 2 randomized trials in the last 10 years.
So exactly.
A question from Carlos Diancona. Do you recommend using Maastricht and Hanover nomogram to select patients with underactive detrusor? I'll leave it to either one of you to take that question, if you can. Do you recommend using Maastricht or Hanover nomogram for select patients with underactive detrusor? I don't use these nomograms at all. So
I don't use it.
No, actually, it is not in my clinical practice, even if it is a very, possibly very important tool to differentiate underactivity from obstruction. This was developed by the group of Maastricht and Hanover, as specified by Carlos very correctly. It is not entered probably in our clinical practice, common clinical practice, but it's something very interesting that may be used probably in the next future.
Right. Next is a provocative question. This is from Michael Guralnik. What are the experts' thoughts on HOLEP versus TURP for a patient with DU or acontractile detrusor and urinary retention? I'll actually rephrase this question. So in a sense, do you believe that HOLEP is more effective at relieving obstruction? Because I'm sure neither of these 2 procedures do anything to the acontractility. So do you believe that HOLEP is more effective at relieving obstruction, or is it the quality of the surgeon who's operating, who's doing an effective job between the 2? Do you think it really makes a difference to the acontractile patient? Tufan.
Well, I would like to say, first of all, hi to Michael and also to Carlos for the previous question. Well, I don't think that there might be any difference. Of course, there is no study that I know in that field, but I think a good prostatectomy, of course, may make a difference. But if you are performing a good TURP, I think that's good enough.
Yeah.
Fair enough. Next question is to me. This is by Alexandre Fornari. I would like to ask Dr. Sanjay if phenotyping patients with OAB according to the potential pathophysiology can change the conservative treatment or the sequence of medications and improve the results. Very interesting question. And we don't have a very good answer to this. There are, if I remember correctly, 3 crossover trials in which they have used mirabegron and antimuscarinic and switched between the two. And essentially what we see is, in one of those trials, it showed that at the crossover stage, the patients with mirabegron had less side effects, but the efficacy was, and the efficacy looks relatively similar. But when they added the anticholinergic, the patients in the mirabegron arm had some incremental further improvement. So it's very difficult to interpret the results, but I think right now our understanding of OAB is imperfect. We know that patients of OAB may have problems right from the central, or from the level of the cortex right down to the bladder, and we really have no good method of identifying where the pathophysiology actually lies right from the brain. If you look at functional MRI imaging, for instance. So it's possible over the near future we will have other medication which will target different areas which we are not targeting at all at this point of time. But certainly patients who have got, we have some broad characteristics by which we can phenotype the patient. So patients who have some element of voiding dysfunction, patients with relatively elevated residuals, I would probably choose mirabegron. Patients who have a history of retention, delayed gastric emptying, narrow angle glaucoma, and so on, those patients I would choose mirabegron. Patients with uncontrolled hypertension, patients with cardiovascular morbidities and all, I may choose an anticholinergic. And patients who are elderly, I'd probably choose mirabegron to avoid long-term cognition problems. If you'd like to quickly add something to that, or if you have a completely different take on this, I'll leave it to either of you. Otherwise, I'll go on to the next question. Okay. So a question from Rizwan. Is it really true that 100% of patients with acontractile bladder are able to pass urine without need for self-catheter? Are there any more studies than the one quoted? You didn't quote 100% results.
No, right.
Yeah.
Probably I was a little bit too fast in showing my slides. No, the study that I showed didn't say that. Rizwan, hello. But the study reported exactly the opposite, that around 70% of patients still needed antidimited catheterization after TURP. So sorry for being maybe too fast in showing my slides. So again, to go back to the message, because I have seen there is also another question by Matthias Oelke about results of TURP in underactive detrusor patients. I think that if we have detrusor underactivity, I mean, the indication of a TURP is possible. Of course, we have to discuss with the patient that the results of a disobstructive procedure in these patients may be less satisfactory than in a patient with the pure obstruction. And this is a very important point also about the utility, the usefulness of urodynamics before surgery also in male patients. But I'm convinced that in underactive detrusor patients, the surgery can be performed, of course, with a possible less good results. With an acontractile detrusor, usually in my clinical practice, when I see a patient with a real acontractile detrusor, so when I'm sure that the detrusor is really acontractile, so repeating several times urodynamics and so on, I usually don't go for this obstruction. I prefer to go for intermittent catheterization directly. With some exception, maybe, but my usual practice is this. Tufan.
I think we have the last 2 minutes. I will hand it over to Tufan for his concluding remarks. And if there are any questions which are unanswered, we will try and get back onto the ICS website if possible. Yeah, and we will try to answer our individual questions for you. Thank you all very much. Delighted to do this program. Tufan, back to you.
Thanks again. Thank you.
Yes, we have come to the end of this webinar. Actually, we have spoken about different issues, but I would like just to emphasize the importance of urodynamic studies. The 3 speakers of this webinar are true believers of urodynamic studies. And actually, we took this opportunity to mention the importance of urodynamic studies to define detrusor underactivity. For example, to define refractory overactive bladder syndrome, and before proceeding to more invasive treatments, the importance of the urodynamic studies for us is very clear and valid. But still, of course, there are many research to be done still left. For example, we don't have yet the precise urodynamic definition of detrusor underactivity, for example. So I think more research here is certainly warranted, but urodynamic studies are the best tools that we know so far to describe us what's going on in the lower urinary tract. And really, if we cannot help our patients with conservative measures, actually in my clinical practice, urodynamic studies are warranted. I would like to thank, first of all, the ICS team for this very nice webinar, for their kind help, to Rob, Ashley, and Avicia. We three of us really appreciate their help. And I also would like to thank all our audience, and especially the ones who made comments and asked questions. And I would like to thank Enrico and Sanjay very much, my good two friends, for making this webinar possible altogether. I wish everybody a very nice, weekend and good time without COVID. I hope that this COVID pandemic will soon end up, but the data shows us that it will continue. It will continue. So we have to establish our new normal once we are sure that our health systems are not overwhelmed with COVID patients. So thank you very much, and goodbye to everybody.
Thank you very much. Bye.
Thank you. Bye.